Okay, that's everyone in.
Vicky, should questions all be in the chat box, or do people get to ask questions live, as some people, I've seen it both ways.
Yeah, I think most people or most chairs ask them to pop them into the chat and then
Okay.
ask them at the end of each of the presentations.
Okay, and then if someone really wants to ask it live, we
Yes,
can
yeah, they
certainly
can
let
unmute.
that happen.
Yeah.
Lolita, do you think we should start?
Yes, I do.
3
All
minutes
right.
past.
Well, Simon, why don't you just get going?
Okay, thanks very much. So today is the day when we, one of the 2 days a year when we step out of the hospital and go into the community. This is Lensfield Medical Practice, where I work 1 day a week. So if you need to avail yourself of a GP and you're registered at Lensfield, try to make sure it's not a Thursday. Otherwise you might have the misfortune of seeing me. The first thing I'd like to do is acknowledge that much of the work I'm going to present here is has been led by my colleague, Dr. Julia Usher-Smith. She's unfortunately on holiday at the moment, so couldn't be here to present. Some of the latter work was undertaken by Becky Dennison and also Chloe Thomas from SHAR in Sheffield, who's a health economist. So let's go to the patient. The first patient is a 67-year-old white male who had not too much notable in their past medical history: vasectomy, pleurisy, piles, glaucoma, shingles, benign prostatic hypertrophy, which was then treated with a laser resection. He had attended for abdominal aortic aneurysm screening, so he wasn't averse to screening, and he'd had some surgery on Ducotrons. His only treatment was atorvastatin. He was an ex-smoker. He drank a moderate amount of alcohol. He had an allotment. He did light exercise. His wife had Parkinson's, so he did have some caring responsibilities, and he was just slightly overweight, but not a significant risk factor for the condition we're discussing. So just some background. In this country, we screen for colorectal cancer. You're invited every 2 years, if you're a man or woman aged 60 to 74. If you're older than that, you can ask for a screening kit by calling that number. The age is going to be reduced to 50. We have been using fecal occult bloods, but that's changed now to fecal immunochemical testing. And if you're positive, you then get invited for a colonoscopy. So this first patient had negative screening tests using fecal occult bloods in, and that's what the kit looks like, in February 2013, negative in 2018. And I've shown here the letters that we get to the practice informing us what's happened. It's a very slick, well-organized system. Unfortunately, in December 20, the FIT test came back positive, and here you can see the letter that we get back for a positive test. So the arrangements for colonoscopy are done automatically. We don't get involved and interfere and block the process. And so this gentleman was invited for a colonoscopy. And this is what we get back from the colonoscopy. And unfortunately, or sadly, as Mr. Hall noted, there was a distal sigmoid tumor that looked like a cancer, which turned out to be moderately differentiated adenocarcinoma with surface dysplasia. So that's what we get back in our records following the colonoscopy. But these days, not only that, we also get the picture. And so you can see here the tumor that was just described. So what happened? Well, again, there's quite a slick system that the patients progressed to scanning and staging. The only problem here, of course, was COVID. And so there were delays in, or there was going to be a delay in surgery. And so the patient opted to be referred privately to the Marsden, where he underwent laparoscopic resection. And the staging after resection is shown here. So just through the inside of the bowel, but no nodes, no metastases. And then a follow-up colonoscopy was normal. So potentially a good result, a curative result from the screening program. Next patient, 69-year-old white male. Again, not too much relevant in the past medical history. Was on no treatment, didn't smoke, and was teetotal. He had a pretty bad last 24 months. His wife had been treated for esophageal cancer, and it was discovered she had a brain metastasis. He also had manic depression, so he had a lot on his plate. His daughter was a doctor in Cambridgeshire, which will become relevant shortly. Again, he didn't exhibit many of the classical risk factors for colorectal cancer. So he didn't take up the offer of screening in 2012 or 2014. He had a normal chest X-ray in 2015. He had normal abdominal aortic aneurysm screening, so he wasn't averse to screening in 2017. His fecal Lockhart bloods were negative in 2018, so he did have that test, and they were negative again in 2021. Around the early part of 2021, he reported a 12-month history of a cough with some sharp pleuritic type pains. It was stopping him from sleeping, and he'd become more short of breath. He also reported a long several-month history of constipation. On examination, his chest was clear. He had no creps, percussion and resonance were normal. He had some tenderness in his right upper quadrant and a liver edge that was palpable. He was started on amoxicillin. The investigations showed a slight anemia, slightly raised ESR. The ferritin, iron, and transferrin are shown there. The liver function tests were elevated, and the chest X-ray showed a raised right hemidiaphragm, although this had been observed on a prior chest X-ray several years earlier. In March, the chest pain was worse on breathing in, and the D-dimer was 3940. He was admitted to hospital, and the investigations in hospital revealed a sigmoid colon cancer with lung and liver metastases. The ultrasound also showed the, which was done around the same time, also showed the liver metastases. A colonoscopy was done, which identified the colonic tumor, although the biopsies were unsatisfactory. The staging is shown here. So it invaded through the bowel wall, had some nodes, and obviously had distant metastases. So he moved to this area to be close to his daughter and has commenced chemotherapy. And the final patient is a 62-year-old white female who's had appendectomy and tonsillectomy. She did, in 2006, report a dizzy episode when attending a Tory party conference, but I think that's a not unreasonable response to attending such a meeting. She had a 24-hour tape and an echo, and that was normal. In 2011, she developed some paresthesia. It was thought at first that it might be a TIA, and she was started on aspirin initially, which, as you may know, can be protective for colorectal cancer. As many of our patients do, she reported a bicycle collision and a neck injury, so not an uncommon entry in the notes in Cambridge, and she'd had wisdom teeth extracted. Her only treatment was thyroxine. She was an ex-smoker, drinking a small amount of alcohol. Again, she wasn't overweight, but she had a quite strong family history of colorectal cancer. So her sister had colorectal cancer in her 40s and unfortunately died in her 50s. She also had a strong family history of cardiovascular disease. So her first invitation to the colorectal cancer screening was in 2016, and her test was positive. She had a flat polyp seen at colonoscopy, which it wasn't possible to resect. The CT and MRI scans were normal, and she had an anterior resection. Her staging is shown there, so no nodes, no metastases. And she's had follow-up colonoscopies, CT scans, and normal colonoscopies and normal CT scan. So again, looks like a positive curative result from the cancer screening program. So in summary, we have 3 patients who had various involvements with the colorectal cancer screening program. They had various starting dates of screening, they had various frequencies of screening, and they had quite different outcomes. So colorectal cancer is the second leading cause of cancer-related death in Europe and the United States, and survival is strongly patterned by the stage at diagnosis. Population screening reduces colorectal cancer incidence and mortality. And indeed, the more screening that you do, the more cancer is prevented and the more cancer is detected early and the more cost-effective the program is. However, there are significant constraints, particularly on the number of colonoscopists and number of colonoscopies that can be done. So the question is, can we improve, can we target, can we better stratify the population so that we make the program more efficient? So all screening programs are stratified to some degree, usually by age and/or sex. So for example, although 1% of breast cancers occur in men, only women are invited for mammography. So the question is, can we use additional information such as routinely held or easily obtained information, or even biomarkers, in order to stratify populations? So the first thing that we did was we undertook a systematic review of risk scores for colorectal cancer. And what this slide shows is the area under the ROC curve, so the discriminative ability of the risk scores. And the risk scores for colorectal cancer perform reasonably well. Even ones that use simple information that's readily available in general practice records now has an area under the ROC curve of around 0.7. You shouldn't be too optimistic about some of the scores to the right, because some of the study designs for the things like genetic biomarkers tend to involve case control studies, which due to spectrum bias artificially inflate the performance. So we then validated these colorectal cancer risk scores in UK Biobank. And again, what you see is reasonable performance. So scores like Q Cancer, which is similar to Q Risk from Julia Hippersey-Cox stable of risk scores, particularly performs reasonably well. What you can also see is the scores perform better in men than in women. So what about genetic risk scores? Well, genetic risk scores, again, there's a range of performance when we systematically reviewed them. And again, some of the heterogeneity is due to features of the study design. But again, it looks like genetic scores, particularly when you add phenotypic information, does have some good discriminant utility. So we then validated the genetic risk scores again in UK Biobank, and again come up with a similar answer, although the many of the scores are lower than in the studies where they were originally developed and tested, but still acceptable levels of performance, such that you might want to consider using them in a stratification prior to screening. The other key thing to note about the genetic risk scores is that the more SNPs you have, the better performing the score. And so with the rise of polygenic risk scores, the discriminant utility will get better. So what about the health economic modeling? What happens when you do a microsimulation model using the MIMIC model, which is from Shah in Sheffield, which is what National Screening Committee use? So we, with Chloe Thomas, undertook this modeling analysis, and we compared sex stratified screening against screening everyone at the same age. So what we found was that screening men from age 56 and women from age 60, rather than screening everyone at age 58 and using a FIT test, had an incremental cost effectiveness ratio of £1,392. And it reduced CRC cases and mortality by 25 and 19 per 100,000 people respectively, while using a similar amount of screening resources. There was around a 61% probability that sex stratification would be more cost effective than screening everyone aged 58. So what about a more sophisticated approach where you use risk scores like I described earlier? So again, this is an individual patient level microsimulation model using the MIMIC model. And it uses data as before from the Health Survey for England. And so what we've done here is we've compared inviting everyone from age 60 with using a risk score to determine the fit screening start age. And what we find is that you have an improvement in QALYs and a reduction in costs, and 218 fewer colorectal cancer cases and 156 fewer colorectal cancer deaths per 100,000 population, but with a similar number of fit invitations sent out. So there was a 96% probability that risk stratification would be cost effective with a net monetary benefit. So what about what people think about this? What about potential invitees? So we conducted a Think Aloud study exploring the decision-making in more detail. And we also did a randomized experiment quantifying preferences. So participants completed a web-based survey, and then they were allocated to up to 9 scenarios, comparing screening to no screening for 3 levels of baseline risk, 1, 3, and 5% over 15 years, and 3 different screening tests that were less or more invasive. And this is the sort of information that we shared with people that really highlights the low benefit that an individual gets from screening, which is a more public health population-based strategy. But in spite of this, people think screening is like motherhood and apple pie. Screening is a bit like prevention is better than cure. Screening is better than no screening. And what people suggested in the Think Aloud study is that irrespective of the low absolute benefits or irrespective of the level of potential harms, they would still want to attend screening. In the online experiment, 60% expressed an intention to attend at 1% risk of CRC, 70% at 3%, and 77% at 5%, with no differences between the different invasive screening tests. What we found is that using sex, age and sex, or the simple risk score were less acceptable than age. And what was perhaps slightly surprising was that genetics was more acceptable to people than the other approaches. All approaches were less acceptable to women than to men. Over 70% of the participants were comfortable waiting until they were older if the complex risk score or genetics indicated that they had a lower risk. However, being told that they were a low risk had no effect on uptake. So even if you have low risk, you still want to attend for screening. So we then went on to explore the social and ethical implications of risk stratified screening using a community jury. So we recruited people from a market research company, send them an information pack and questionnaires. They then have a morning hearing presentations from the likes of me and Juliet and ethicists and public health doctors, trying to clarify the pros and cons of screening. And they then have a jury day where they have a discussion that's facilitated and a discussion that's not facilitated. And then they come up with their conclusions. And the first conclusion is that there was an increase in acceptability after they'd had the opportunity to discuss this. But again, the genetic risk scores seem to be more acceptable than some of the other approaches. The principle of risk stratification was generally considered to be acceptable. So everyone agreed that screening was essential and that people shouldn't miss out. Those who disagreed just wanted more widespread screening. So there was concern that if we don't screen women at the age of 30, we might be missing some breast cancers. And the danger of missing anybody's cancer, some people found overwhelming. Risk stratification was acceptable for reasons such as improving test accuracy and improving efficiency of NHS resources. So this participant has said, you're testing so many people who think you are such low risk that you're actually going to be wasting money. So the principle of improving efficiency did come across. There was variability on how we should stratify. Any characteristic with scientific justification should be used. So some people talked about using everything, but then there was some concern about how this is decided. But there was generally a level of trust that the so-called big professors that came up with the plan should be trusted, and that the equations or algorithms that were developed by scientists should be trusted. However, there was some variability on how to stratify. So non-modifiable, stable and easy to measure factors were encouraged, and they were preferred over lifestyle characteristics. So people didn't want to have this idea that if you had a poor lifestyle, you should have better access, or if you had a poor lifestyle, you should have worse access. So there was some discussion about the ethical basis behind those sorts of variables being used in risk stratification. So one of the key things was transparency, and that the risk stratification should be, people should be informed about what was going on, rather than just you don't get invited and your neighbor does and you don't understand why. So there are clearly some challenges in implementing a cancer risk prediction tools and risk stratification. So choosing which model to use. Generally speaking, the model that's developed and validated in your population tends to work best in your population. Choosing when and where the risk should be predicted, understanding and overcoming barriers to use, how we communicate the risk and how we communicate the fact that we have got a risk stratified program, and deciding what thresholds to set. So in summary, I've presented 3 patients who had variable experiences, variable contacts with the colorectal cancer screening program. For 2, it appeared to have been effective in spite of the fact that one of the patients was picked up on her very first screen. And for 1 individual, it was plainly not effective. However, risk stratified screening using phenotypic and/or genetic risk scores, and if you use genetic, the more genes, the better, does appear to be feasible, does increase the efficiency of the screening program, and is acceptable to the public. So I'd like to thank all of the co-authors on these various studies that I've presented, and I'm happy to try and answer your questions. Thank you.
Thank you, Simon. That was very effective and efficient and interesting. So maybe I'll kick off with a few questions that I've got. So what is the interval even based on? Like, how do we decide? How was it decided that it should be every 2 years, for example?
So that's a good question. The interval is based on modeling and modeling the development from adenoma to adenocarcinoma. And I guess most of my talk was focusing on the age that you start screening, which is a key important variable. But you're absolutely right that the screening interval is also an important variable. And both things could be stratified. So that if you're high risk, you could start earlier and you could be screened more frequently. If you're low risk, you could start later and you could be screened less often. The other thing that one could bring in here is if you're is the nature of the screening test. So if you're very high risk, you might go straight to colonoscopy, for example, rather than having the screening tests, which, as you see from my presentation, are not infallible.
Right, because your patient too was remarkable for the fact that I was trying to calculate, and it appeared they'd had the screening test literally a couple months before.
Absolutely, yep. So the whole point of the AUC, I said that a risk score was reasonably good at 0.7, but that implies that you've got quite a big drop in sensitivity and or specificity with the risk score. Similarly, you also have with the screening tests. So the screening tests are certainly not perfect. Even colonoscopy is not 100% sensitive, although close to that.
And what is the uptake? Even, let's say, I mean, one thing I couldn't figure out from the talk was even among those registered in a GP practice, what is the positive uptake of in other words, what's the ratio of tests returned to tests sent out?
So I don't know the exact figure, but I think the screening uptake is around 70%.
Okay.
but I'd have to get back to you with an exact figure for that.
Okay, well, I don't want to hog all the questions. There's questions for everybody. Adam Butterworth says, great talk, Simon. What's your sense of why people found genetics a more acceptable screening variable than others, like age and sex, which I think is a very interesting question.
Yeah, I think that is interesting. I was slightly surprised by that. I think that I can understand better the fact that genetics would be preferred over lifestyle behaviors, which starts to bring in some sort of ideas of prejudice. But I think the issues about equity, that having one segment of society like women having a later access to screening than men, particularly the women, might have found more difficult. There was, if you noticed, a sex-specific difference in acceptability.
Yes.
So I think maybe if we'd asked this question 10 years ago, even 20 years ago, we might have got a different answer in relation to genetics.
I wonder if you'd get a different answer depending on which postcode you went to.
Yeah, although in our analysis, we adjusted for socioeconomic status.
Okay. All right. Fiona says, great talk. How do we persuade the policymakers that we should move to a stratified program?
Well, that's a very good question. And I applied to be a member of the National Screening Committee as their GP member. And I travelled down to the interview and was kept waiting about an hour and a half. And then I was unsuccessful at interview, possibly because I brought up the issue of stratified screening as one of the key things that I would want to see if I was successful in my tenure of membership of the committee. I think the key thing about the NSC is they want to make sure that the system delivers well and efficiently and effectively on a wet weekend in Wigan. In other words, it has really good coverage and it works really well and people don't fall through the net. The NSC gets concerned when a screening test is not done properly, not returned, not read properly. So when there are mistakes. So introducing complexity like stratification increases the complexity and therefore the chance of error, the chance of the system not working well. But I think, I mean, all screening programs are stratified now. It's just that they're just stratified by things like age and sex and don't use the more valuable, more nuanced information that we now have available. But I think it will come.
John Firth wants to know, wants you to examine his perspective. He says his prejudice is that people who participate in focus groups and research studies are more likely to be inclined to support screening. So are you going to do you have some intrinsic inherent bias in the results you get from these?
So our surveys, you can only report the data of the people who respond. And when you do online surveys, you tend to get people who are computer literate and who want to earn money in those sort of things. So I wouldn't necessarily say that it's a representative sample. However, the sample did draw from people from different socioeconomic groups. But John, you're absolutely right to touch on this issue, because that's the one really big problem with screening, is that it tends to increase inequalities, because people who are better educated, women, people who have a good diet, who don't smoke, who drink moderate amounts of alcohol, who wear lycra and who are physically active tend to take up the offer of screening, whereas deprived, poorly educated men who smoke and who are inactive tend to not take up the offer of screening. Now that's a rather gross categorization, but that tends to be the case. So if screening is beneficial, which it is, then all screening programs tend to increase inequalities, which is a real problem. So what we then need to do is, if we know it's effective, is we then have to have better ways of improving uptake and adherence to screening in those deprived, hard to reach communities.
I imagine that is reflected in the demographics of the breast cancer, the epidemiology of the of the colon cancer itself, right? In the patients. I mean,
well, actually, breast cancer.
I meant colon cancer. Sorry.
Yeah, breast cancer doesn't exhibit that socioeconomic happening, whereas colon cancer does.
Yeah. Great. Okay, I think we're almost done. I have one last question about the breast cancer, actually, that you just touched upon. You said that we don't screen for men with breast cancer because it's only 1%. Is the other reason that it's easier to, that it would be easier to pick up without screening because they would notice something more likely, or is that not actually the case?
Well, they probably would, although that depends on the level of obesity.
Yes.
Technically, mammograms are obviously harder to do in men than women and therefore harder to read, but one would never consider screening for something that's so rare.
Yeah. Okay,
with the available technology we have.
Yes. Well, thank you very much. We should probably move on. So if you could stop sharing your screen, we can get to the next talk then.
That one. And then put it into presenter mode. Just do front slides.
Okay,
Hello.
excellent. So
Good afternoon. Thanks for the opportunity to speak today on behalf of the Stroke Department. The title of my talk is Carotid Atherosclerosis, Too Narrow a View. So I'm Dr. John McCabe. I'm a stroke clinical fellow here at Addenbrooke's, and I'm delighted to have the opportunity to speak. So just to give you an idea of what I'm going to discuss today. So I'm just going to start with some very common case examples of clinical scenarios we see and our vascular surgical colleagues see on a very frequent basis. I'm going to review some of the evidence for carotid endarterectomy in symptomatic carotid atherosclerosis. We're going to review some of the biology of atheromatous plaque and specifically look at inflammation and atherosclerosis and how this may be relevant. Then I'm going to present some of the data from my PhD during my time with the Stroke Clinical Trials Network in Ireland, and looking at carotid PET imaging and recurrent stroke. And as many of you know, carotid PET imaging is something that is, and vascular PET imaging in general is something that is of a high research interest here in Addenbrooke's and in Cambridge. So I'm also going to look at inflammation in small vessel disease, and this is something that, again, and the stroke research group here at Addenbrooke's, including Nick Evans, has been looking at recently, and also some of the future work we may look at both here and across the water on how this may relate to future directions of research in this area. So just to give you, by way of introduction, our first case. So this is not a real case in a sense, but it's a case we see very, very frequently. So it's a 65-year-old female who 4 weeks ago had one episode of transient visual loss in her left eye lasting 5 minutes with full resolution. She's a smoker and she's hypertensive, but she's otherwise fit and independent. And her stroke workup does not identify any evidence of atrial fibrillation. And then on her CT angiogram, you can see there's evidence of a plaque at the origin of the left internal carotid artery, measuring about 50% on luminal measurement. So this patient, in summary, has a symptomatic left internal carotid artery stenosis, which has caused an amaurosis fugax. So the question is, and I would like you just to think about it yourselves, whether or not you should, based on the the evidence available to us, should you offer this person a carotid endarterectomy or best medical therapy? The second case is very similar in some ways, but also quite different in others. So it's a 75-year-old gentleman who 2 days ago had one episode of transient left upper limb weakness with full resolution. He has a cardiac history with previous PCI, but he's got good exercise tolerance and is a good surgical candidate. He does not have any atrial fibrillation, but again, similar to our first case, he's got a right internal carotid artery stenosis measuring 50%. So again, in summary, this is a person who has had a very recent TIA, and so he's got a symptomatic right internal carotid artery stenosis. So would you offer this gentleman surgery or medical management? So just a kind of a bird's eye overview of carotid atherosclerosis. So it's a subtype of stroke that we see in about 10 to 20% of our strokes that come into the door every single day will have a symptomatic carotid stenosis. And carotid atheroma and carotid atherosclerosis in general, unlike other stroke subtypes, has a very high risk of early recurrent stroke with about a threefold increased risk compared to other stroke subtypes. So these are the sort of patients that we really worry about, and is one of the main reasons for really having a TIA clinic and having early access to vascular imaging is to identify these patients and get them on appropriate treatment and to offer them surgery at an early stage. And data from 3 randomized control trials carried out nearly 3 decades ago now has shown that when you pool the data, that for symptomatic carotid artery stenosis, the greatest net benefit from carotid endarterectomy was seen in patients with severe stenosis. The absolute risk reduction compared to best medical therapy in these trials was 16% to prevent 1 stroke at 5 years. So by contrast, patients with moderate stenosis, so those with stenosis between 50 and 70%, had a benefit from surgery, but the benefit was overall essentially modest, with an absolute risk reduction of 4.6% to prevent 1 stroke at 5 years. And no benefit was seen in patients with mild stenosis. And it's based on these trials, really, even though they are quite a bit, they were carried out nearly 30 years ago. It's on the basis of these trials that we make our decisions mostly on a day-to-day basis. And so they continue to inform modern day clinical practice, but basing our decisions on luminal stenosis as a risk stratifier is probably inconsistent with some of the more complex biology of plaque atheroma, which I will review now. Just before we get on to that, this is a very important slide in terms of interpreting our 2 cases. So this is from Peter Rothwell's publication in The Lancet now nearly 20 years ago. And these are subgroup analyses of patients enrolled in the 3 randomized controlled trials I spoke of. And as you can see here, if we look at patients with moderate stenosis, there was a clear benefit from surgery in men, with no clear benefit in women. And interestingly, with increasing age, there was more benefit seen with endarterectomy. So clear evidence for endarterectomy in over 75s, with no clear evidence of benefit in patients under the age of 65. And very importantly, and again, this comes back to this issue of the urgency of this condition, patients who were operated within 2 weeks of their most recent event had far more to gain than patients who had a delay to revascularization. And that is consistent with what we know about the natural history of symptomatic carotid atherosclerosis, which is this early high risk period is the time which we need to act. Again, if we look at the subtype of the most recent vascular event, so whether it was an amaurosis fugax or a stroke, we can see that there was no benefit in patients with retinal events, but clear benefit in patients with mild non-disabling stroke at baseline. So if we take our first case, it was a 65-year-old woman who had an event 4 weeks ago, and her event was amaurosis fugax. So she has several criteria that would suggest that she may be less likely to benefit from surgery versus medical therapy. In contrast, our second gentleman is 75, and his event was just 2 days ago, and it was a TIA. So he's got more potentially to gain, at least from this data, from surgery. So to put this in context, if we look at the number needed to treat, so the number of operations we need to do to prevent 1 stroke at 5 years, there's quite considerable differences between these subgroups. So for a man, the number needed to treat is 13 versus 37 for a woman, 9 for those older versus 77 for those younger. And again, this issue of delay to surgery. So if you're done within 2 weeks, the number needed to treat to prevent a stroke is 7 versus 25 to 30 for those with delayed surgery. So with that in mind, really, there is a clear need for new strategies for risk stratification purposes, so that when we see these patients with moderate stenosis and we're uncertain or we're wondering about surgery, and there may be some other reason why we don't want to do surgery, perhaps because the patient is frailer or older, we might use more risk stratification purposes, risk stratification processes to try and identify those at greatest risk of recurrent stroke. And one of these areas of interest to me and also here in Addenbrooke's is plaque inflammation and its relationship to recurrence after stroke. So many of you will recognize this slide or something similar from your textbooks as medical students. This is the natural history of atherosclerosis. So early atheroma can stabilize over time and have a very thick fibrous cap that's less likely to rupture with a small lipid pool. So these plaques can sometimes become calcified over time and be less likely to become symptomatic. Or more inflamed plaques can become more unstable. And hallmarks from a morphological perspective of unstable atheroma are thin fibrous plaques, thin fibrous caps, which are much more likely to fissure, which will expose the underlying lipid pool to blood and trigger the coagulation cascade, forming a thrombosis. And these plaques tend to be more inflamed as well. And moving on to this issue of inflammation, it is now well recognized that inflammation plays a very clear role in the development of atherosclerosis, progression of atheroma, and also ultimately destabilization. So more recently, and of course, as is the case often with stroke, we tend to follow the work done by our colleagues in the coronary field. And a lot of the interest in plaque inflammation has come from coronary artery disease research. But now we realize that plaque inflammation is particularly important for stroke recurrence in a stroke population. And we know that histological features of plaque instability and plaque inflammation are independently associated with an increased risk of stroke recurrence. Anti-inflammatory therapies from a broad array of randomized controlled trials for colchicine, but also canakinumab. These anti-inflammatory therapies have been shown in recent years to reduce the risk of major adverse cardiovascular events. But these trials were done in patients with coronary artery disease. And so we don't have any phase 3 randomized controlled trials to date that have published evidence that anti-inflammatory therapies may reduce risk in stroke patients. But for instance, in the trials of colchicine that were published in the New England Journal the last year or two, again in a coronary population, the risk of stroke in those studies was approximately halved on patients taking colchicine compared to best medical therapy. So there's also strong emerging evidence for an independent association between blood inflammatory markers such as high sensitivity C-reactive protein and interleukin-6 and the risk of major vascular recurrence after stroke. Moving then on back to carotid atheroma specifically, 18-FDG PET is now well validated as a technique for identifying inflammation-related plaque metabolism. And this has been well described, of course, by James Rudd nearly 20 years ago now in Circulation. And this has gone on to form the basis of a lot of the research that has been done in the Stroke Clinical Trials Network in Ireland on this topic. So what is the basis of it? Well, activated macrophages in atherosclerotic plaque have high metabolic activity and therefore high FDG uptake. And this is what we measure when we do a carotid PET CTA. So in these two figures, we have a patient coming back to our patient with moderate stenosis. You can see this patient has an irregular plaque within the origin of the internal carotid artery. On PET imaging, it lights up very avidly. So you can see here the plaque is lighting up. So this is a person who has a very highly metabolically active plaque within their carotid artery. How do we do a carotid PET? Well, we take, this is the protocol from our studies in Dublin. We take 5 slices above and below the maximal area of luminal narrowing, and we measure plaque inflammation within each of these slices. And the hottest slice we refer to as the single hottest slice, and we take this as our main area. This is our measure of plaque inflammation. And it is measured using using SUV max, which is the standardized uptake value. So anytime I mention this, it's just a marker of carotid plaque inflammation that we use. So thanks to Nick Evans for providing me with the slide. So this is looking at if we take the slices through the carotid artery, we take the single hottest slice, and this is what we call the so the single hottest slice is here as we can see. So in the study, as part of my research, we had 3 prospective multi-centered international observational cohorts. Eligible patients in these studies that were done had recent non-disabling stroke or transient ischemic attack with symptomatic carotid atheroma greater than 50%, ipsilateral to the stroke, of course. And these patients underwent carotid FDG PET shortly after their most recent event. And the primary outcome in these studies was recurrent stroke. The research questions we were asking in these studies was, could carotid plaque inflammation imaged by PET be associated with recurrent stroke? And could PET imaging help identify patients at greatest risk of recurrence? So this, in the first of a number of papers we've released on this recently, was published in Stroke in 2019. And we showed that carotid plaque inflammation was strongly associated with an increased risk of recurrent stroke, and this was independent of the degree of luminal stenosis. Then we went on to try and create a scoring system that incorporated luminal stenosis with plaque inflammation into a single score. We call this the scale score, and it's measured from, it's a score that ranges from 0 to 5. So you get a maximum of 3 points for the degree of plaque inflammation and up to 2 points for the degree of luminal stenosis. So just to illustrate two examples, both patients here in these cases have moderate stenosis, so they get 1 point. This is a very inflamed plaque, as you can see, so the SUV max is quite increased, so this total scale score is 3. Again, in this second case, a patient with moderate stenosis, they have a rather uninflamed or non-inflamed plaque, and so they get a scale score of just 1. So this was, we looked at the scale score, and it was shown to be associated with an substantially increased risk of early recurrent stroke at 90 days with an adjusted hazard ratio of 2.4. So this essentially means for every 1 point increase in the scale score, there's a doubling in your risk of early recurrent stroke. And as you can see, this is clearly illustrates across categories of scale score, there's a clear linear increased risk of recurrent stroke. One of the unanswered questions from these studies, however, was what about late recurrent stroke? So we'd related plaque inflammation to early recurrent stroke at 90 days, but the question about whether or not it predicts late recurrent stroke was unanswered. So as part of my PhD, we went back and we did a late follow-up assessment on all patients. And again, we showed that carotid plaque inflammation measured with PET imaging was associated with late recurrent ipsilateral ischemic stroke at 5 years after adjustment for important confounding variables that included whether or not the patient had surgery at baseline and also the degree of luminal stenosis. And again, the scale score was strongly associated with 5-year recurrent stroke. And this data has just been published in Neurology in the last couple of weeks. When we dichotomize the scale score into two groups, so patients with low scale scores below 3 or a scale score of 3 to 5, the risk of 5-year recurrent stroke was just 2.6% in patients with a scale score of less than 3 versus 14.3% in those with a scale score of 3 or greater. And so in summary, carotid plaque inflammation imaged by PET is strongly associated with recurrent stroke, and carotid PET imaging can help risk stratify patients with uncertain benefit from endarterectomy. And we think now that we need randomized trials to really test the hypothesis of whether PET imaging can be used to identify patients with uncertain benefit from endarterectomy. So during the review process for neurology, the editorial committee asked for an independent review to look at the evidence and class it. So it was given class 1 evidence during the review process for the role of PET imaging to identify stroke recurrence in patients with TIA or minor ischemic stroke. But the story doesn't end there, and this comes back to some of the really interesting research that has been done in the last couple of years by our research group here in Addenbrooke's, and largely work done by Nick Evans, looking at the association between vulnerable plaque and vulnerable brain. And this comes back to the issue of small vessel disease, which of course is essentially a different stroke subtype. And as we know, small vessel disease exists as a spectrum of small ischemic strokes to more severe diffuse leukocariosis. And small vessel disease doesn't just cause stroke, but it also causes dementia and depression, as well as physical disability. And the underlying mechanisms behind small vessel disease vary from arterial narrowing and occlusion, which almost certainly plays a role, but also more recent theories suggest diffuse endothelial failure with impaired cerebral autoregulation and impairments in blood-brain barrier function. And probably an unexplored but important factor in all of this is inflammation as well. And this is something that requires further study. And atherosclerosis, as we know, is a systemic inflammatory condition. And so it is thought, or it's hypothesized, that chronic pro-inflammatory states, perhaps such as that seen in atherosclerosis, might prime or precipitate blood-brain barrier dysfunction, and this may mediate progression and development of small vessel disease. So this theory was hypothesized in the Icarus study here in Addenbrooke's. And in this study, it was hypothesized that high inflammatory activity measured by FDG uptake within carotid plaques in patients with ischemic stroke would be associated with more extensive small vessel disease, but also may increase evolution of infarct size over time. So this work was just published in Frontiers of Neurology. And again, it was found that the degree of plaque inflammation in the symptomatic culprit artery was associated with the degree of white matter lesion volume in the brain. Interestingly, the association was significantly stronger in the non-culprit or asymptomatic carotid plaque. So the degree of inflammation in the contralateral plaque seemed even more associated with degree of white matter lesion volume than the symptomatic plaque. And that might seem like an unusual finding, but it suggests that the degree of inflammation within the asymptomatic carotid artery is a good barometer of what's happening on a systemic basis, whereas the culprit symptomatic artery might be confounded by the acute inflammation associated with the plaque rupture itself. So it may not be as good a marker of systemic inflammation. Finally, the degree of plaque inflammation was related to the degree of infarct volume size as it had changed over serial imaging on MRI. And again, there was a strong association seen between degree of plaque inflammation and the evolution of the infarct size over 90 days from the index event. So it seems that carotid atheroinflammation is also associated with both acute and chronic cerebrovascular disease severity. And these intriguing findings certainly require more investigation in future work. And so this brings us on to what next. And I'm going to briefly, maybe because I'm running out of time. This is a study being done now in Cambridge, looking at, it's called Daedalus, which is looking at combined carotid and brain PET imaging relating to degree of plaque inflammation within the carotid artery to degree of brain inflammation distally. And another research study is looking at sodium valproate, which may have a role in inhibiting HDAC9, which was identified in a genome-wide association study to be an important driver of large artery stroke pathogenesis. And in this study called the SOLVE study, patients will be randomized to best medical therapy versus best medical therapy plus valproate. And the outcome of this study is the degree of change in plaque inflammation measured by FDG PET and serially imaged at baseline and at 12-week follow-up. And then finally, looking more internationally, the CONVINCE trial is an international phase 3 randomized control trial, which is enrolling actively patients with non-cardioembolic ischemic stroke that's non-disabling and the patients have been randomized to low dose colchicine at a dose of 0.5 milligrams plus medical therapy versus best medical therapy alone. And the primary outcome in this trial is any major adverse cardiovascular event. And there's over 2,500 patients now recruited to this to date, and the full target is expected to be accrued by early next year with results in 2025. So briefly in conclusion, advanced imaging may help risk stratify patients with symptomatic carotid disease. and therapeutics for carotid artery disease really have not moved forward greatly in the last 20 years. And I think this is something that we really need to work on as a field. And targeting plaque inflammation may be a fruitful target, although this has not been proven to date. And inflammatory mechanisms within small vessel disease certainly require much more exploration. So I'll be delighted to take any questions. And I have Nick Evans here as well, if there's any questions in relation to the work being done here at Cambridge. So thanks very much for listening.
Okay, terrific. There's a few questions in the chat and I'll start bringing them up. So Simon Griffin wants to know when he says that measures like CRP are independently associated with outcome, but don't add much predictive utility to traditional risk factors, does your scale score actually improve the AUC?
Yeah, that's a really good question, and we have actually looked at this in the papers we've published, and it does improve the identification of recurrent stroke compared to luminal stenosis alone. So that has been shown that it does improve the identification of recurrent stroke, and it's a good point about C-reactive protein, because while this is a marker of great controversy in the coronary field, it seems that it probably isn't a great marker for identifying patients at risk of major adverse cardiovascular events. But it probably does suggest, however, that more other epidemiological work does certainly suggest that inflammatory processes have an independent relationship with major adverse cardiovascular events in both a stroke and coronary population.
Paul Edelstein says that apart from risk stratification, what evidence do you have that stratified intervention based on carotid risk score is beneficial versus just non-stratified intervention?
I think that's a really important point, and I think it's something that it's a clear, that's a really important point. We don't have any evidence that any risk stratification tools actually, other than the subgroup analysis, of course, which is that were done in the randomized trials I spoke about, but there has been no randomization based on risk stratification tools, and I think that this really needs to be done. The issue really, I think, for the field is trying to carry out randomized control trials in this area is difficult, because patients, it's difficult to persuade surgeons and indeed stroke physicians about clinical equipoise, particularly given the results of trials. But I do think that we need to use advanced plaque imaging, whether it be MRI or PET, to try and really try and move the field forward. So I do think we need randomized control trials before we use PET imaging in clinical practice.
Yeah, I mean, so in just following up a little on those people who, this is not like, for example, your stool screening. This is, I mean, people who normally get screened are, is it because, who gets screened normally? Is it because they have risk factors? Is it because they've had some symptoms?
I think it's important to kind of really clarify that. So the patients we're looking at here have symptomatic carotid atherosclerosis, which is a very different sort of animal to patients with asymptomatic carotid atheroma that is incidentally found.
Yeah.
So these are patients that have had a TIA or a non-disabling ischemic stroke, and these patients carry a very high risk of early recurrence. It's probably somewhere in the region of 10% at 30 days, even sometimes with best medical therapy. So they're very different sort of group of people than asymptomatic carotid atherosclerosis, who probably have a much lower stroke risk, probably about 1% to 2% per year.
Okay, one last question, because I know it's very late. I was puzzled by, given what you've just finished saying, I was puzzled by the fact that people who are more than 75 benefit more than the younger cohort. Why on earth would that be?
I think we don't know the answer to it unless other people do. Other people in the audience may know. I think it could be that. I mean, certainly age seems to be associated with a greater degree of systemic inflammation, and perhaps the plaques in older patients are more likely to be unstable. That might be one reason. I don't really know if there's any other reason for it. But I think it's an intriguing idea. But certainly age is a poor prognostic indicator in outcome in general, and is a well-established risk factor for recurrence in general stroke patients, and not just in carotid disease.
And I would just add to that is that actually, if one then looks at frailty measures, actually there's a fairly strong association between frailty and vascular inflammation, atheroinflammation on FDG. So I think it's actually very often this idea of inflammaging, and actually it may not be to do with age, but rather representing the variability that one gets much more pronounced in the function when somebody gets then to that older age category.
Okay. Yeah, because I mean, if you had said the opposite, if you had said you'd found the opposite, I would not have been a bit surprised, because oftentimes pathology is worse in those who are younger, you know, that these are people with greater risk, which is why they're getting this earlier in the first place, and have had more time. In other words, their link to the pathology is longer.
But I suspect that the older individual and the frailer individual, not to necessarily conflate the two, but they are probably going to be the ones with the more inflamed plaques from what we've seen. And perhaps these are the individuals to intervene in.
Yeah. Okay, well, thank you very much. Thank you to both you and Simon, and see you next week.
Thanks very
All
much.
right.
Thank you.
Bye-bye.
Bye-bye.